Now we are off to our final speaker before lunch. Cheryl Rosa-Fingal. Cheryl is the Inspector of Healthcare at the Aruba Healthcare Inspectorate, where she has served since its exemption in 2017. She has specialized in quality and safety in healthcare for over 2 decades, holding a master's degree in health, economics, policy, and law from Erasmus University. Cheryl and her team has been instrumental in the assessment of policies and protocols that promote patient safety and ensure the delivery of high-quality care across the island. Cheryl was adamant for me to give her team also props because they do a very good job in the day-to-day assuring that our island is safe and has high-quality health care. Her extensive experience and commitment to healthcare safety has made her a respected authority on regulatory matters, and she continues to be an advocate for continuous improvement in the quality of care provided to our residents. Please join me in giving Cheryl a very warm welcome.
Thank you. This is a big joy. Two of my favorite topics in my life is God and quality of care, and I'm blessed to have this this conference. Also, I would really like to welcome two special guests that just entered, General Molenaar and Colonel van Klink. Yes. General Molenaar is the Inspector General, and Colonel van Klink is the Deputy Inspector General of the Inspectorate of Military Healthcare in the Netherlands. Since we only exist for 7 years, or we already exist for 7 years, is how you want to look at it, and we need all collaboration and assistance, and they really helped us in the oral healthcare sector. We went with our inspections there. So if those here present think that we are tough in the oral healthcare, it's because we have these two ladies assisting us. So thank you even to support us today with your presence. My topic goes about connecting the dots of quality in healthcare. I really like how this morning we all complimented each other, and because I'm the last speaker, I was really, that's what I'm going to talk about, and Dash already mentioned that, Jabert already mentioned that, Olga already mentioned that, and thank you to Chrissy and Marianne also. So basically, figuratively speaking, connecting the single stars, you're all stars in my optique, but it's just the quality components that you use in your daily practice and you combine them into constellations. So we are talking about how can you move from a fragmented, ad hoc and incidental system, what most of you have, to a continuous, conscious, purposeful and systematic quality improvement. I will be talking in 2 parts. My presentation contains 2 parts. One is the annual quality report feedback we promised you. And the second part is actually the bridge that you see from the feedback we receive from that and connecting the dots actually. So to start with the reports, this year you have received a revised annual quality report. You have all zoomdrami hopi. And you did not like what the inspectorate came with. And we revised our report. Why? Because the last 6 years, actually, it's like we were asking you, pop your hood or your bonnet if you're from England, and check the engine for the different parts under your motor. Now we shifted the focus in our report to, okay, does it work? Does it drive you from A to Z? Because sometimes in front of Hamaka, I see all these old classic cars and I think, yeah, vroom, vroom, but does it carry you from A to Z? So that is actually the shift what we did with the revision. For this feedback, we chose 2 questions. And in the years to come, we will focus on certain parts of the report to give you feedback on it. So we chose for this year actually one of the cardinal questions in the quality assurance and quality system. How do you know that good quality care is provided in your facility? It seems no-brainer. But never have we asked you this question, and you have never answered this question. And which quality system do you use? For that to be able to analyze the data, our esteemed colleague, Dr. Stephen Cruz, he developed this data collecting tool. Actually, what he did, in order to all the data that we get from inspections, from the reports, from every data that we receive when we go to your practice, we have to categorize the data, and we connect the data to main categories. What he did, he took 6 well-known quality systems, some of them you've already heard today, and he looked at the common denominators of all these quality systems, and he made common denominator main categories. So you have the patient-centered care and experience, clinical quality and safety, resource management and infrastructure, regulations and legal aspects, and communication and information sharing. We needed this tool to thematize, to organize, to segmentize the data that we get, and to see in the landscape of quality, where are you at? So the disclaimer, the qualitative analysis is based on your self-reported data. Mind you, it's not a very comprehensive feedback what I'm going to give, but it's a beginning, because this is our improvement. For 6 years you did not receive a feedback from us, so we are improving also. This is a promise also, so let this be the start. For the coming years you will be receiving more in-depth feedback on your self-reported data. This is the sample. Actually, on the moment that Dr. Stephen Cruz, he started his analysis on the reports that we received, he included 108 reports. You can see the division. I did a calculation yesterday, and this is 65% of all the reports that were submitted. There were 166, still 4 of you left. I'm going to... Hari. He normalized the data as well for the fair comparison for the different sizes of the groups, and for better per report insights. If you don't know who Dr. Stephen Cruz is, this is my esteemed colleague there in the back handling our audio vision today. So he could identify 35 keywords. You have 108 reports, a lot of data coming from all these professional groups, and words became a keyword the moment that 2 or more healthcare professionals or healthcare institutions mentioned the same word. So from there on, I'm not going to read them all out, but have a go at them, just look at them. These are the words that you used in your reports to tell us what you think about your quality. How do you know that you're delivering quality, and what is your quality system? The top national keywords that came out of this analysis were patient feedback, continuing education, none and blank. That means, again, you will see it in the figures, that means that either you didn't write anything and you said, thunder up, or you said, I do not have any. We promised for this year, it's new for you, it's new for us. So it was okay to answer or not answer this. But for the years to come, this will not be accepted anymore. Complaint policy, professional standard, quality indicators, international accreditation, quality management system. The 8 is consultation of other specialists. 9 is consultation of staff, and availability or continuity of care. So these top 10 words were used by your reports describing how do you know that you're delivering good quality of care. There, we divided that in 8 professional groups. And this is a bit of the feedback. I don't know if it's really readable in the back, but what you can see from family physicians, the pharmacists, the physiotherapists, the institutions. The institutions are, for instance, the both hospitals, Respaldo, so bigger institutions are in that. Wit-Gele Kruis also forms part of the institutions group. So you can see that there are different top keywords used in the different professional groups to describe What do you think about your quality? Laboratories, oral healthcare, medical specialists, and the midwives. What you can see also is where the none and the blank comes. It is important because you will see, I may be joking, but this is the reality what you have to deal with and what we have to sort out and help each other with. So what Stephen then did is he mixed the matrix that he made as a data collecting tool, and he mixed them with the keywords. So basically it provided focus, insight on the focus of your keywords. So just remembering, these were the 35 keywords. It means that 2 healthcare providers or more mention the same word in their report. Then it becomes a keyword. And here you can see his matrix. And then you understand why Stephen made this matrix, because we have to like put a matrix over your data to make cheese out of it, Jabet? To make it more understandable and to quantify, to group it, to categorize it. So what you see here now, talking about connecting the dots, I was talking about stars and constellations. So figuratively speaking, basically these are your stars. These are the keywords that you presented. Do I have to be closer to the mic, my team? Am I good? Thank you. I love my team. Closer, okay. So these are the stars that you came up with, and these are the constellation that they refer to or they connect with. And these constellations, these are elements, subcategories from well-known quality systems. What we see, I spoke to some of you and called me up and said, what were you guys thinking of giving us such a task with the report, and I do not have time for quality. And we say you already do quality. Dr. Hakim, you already do quality. Only you have not categorized it as that. And maybe you don't even know where your constellation is at. Because otherwise every day you would have that patient's point. So, and there we go from, there you will see how you can go from a fragmented system or not conscious, what you're really doing, you're already doing, to a more purposeful and continuous conscious system. So if you look this in a nice web diagram, you can see all the 9, we took out the blank none. I thought last night, oh, that's a pity, so you could see how many gave that as a keyword. But here you can see how from the top, this is the top 9, but depicted in a web. So you can see which words did you use more to describe where your quality, what kind of quality do you, how do you know that you're delivering good quality of healthcare, and which system do you use? Again, you can see for the 8 groups, and I'm not going to go in depth into this, but it's very interesting to see that the different professional groups obviously use different focus, different keywords to describe. And I'm not even sure yet, but it looks like if you have an institute that is already accredited, maybe you only go for the top bit, and you only are busy with the results and the outcomes, the quality outcomes, because you already have incorporated the rest of the elements. So breaking down this, to end this part, you will see that how do you know that good quality care is provided in your facility? You use these 35 keywords to describe that. And for the answer to the second question, which quality system do you use? The percentage of healthcare clinics and institutions in Aruba that have an implemented and certified accredited quality system is 7%. Exactly to be exactly 7.14%. So Joaquim, you're not on your own. I always love to pick on Joaquim, he knows that. And the other 93% are mostly fragmented components of a quality system, or you answered, I have none. The most common used reason. I explicitly do not use the word excuse, because I know it's not an excuse. It's a reason, it's a mind shift, and it's your reality. So mouth is dry. The realiteit is that you say you have no time. And again, it's not an excuse, it's a reason. Just what we heard Joaquim asking the question to Dasha, there is not much time in a day next to giving care to the patients. Continuing to the second part of my presentation, I would like to bring you to Alice in Wonderland. So Alice meets up with this cat. I refuse to name the name of this cat because otherwise I'll be tongue twisting myself more. So Alice comes across the cat and says, where should I go? And the cat answers, well, that depends on where do you want to end up. Alice answers, I don't really care where I end up. I don't know where I want to end up. So the cat answers, if you do not know where you are going, any road will take you there. So one of the basic principles of quality, I can speak about this not only today, but in years to come. One of your first focus is direction. Direction, where you want to go. This is the plan, do, act, check. Thank you to Dasha. What I said, we complement each other perfectly today. The plan, do, check, act. And I've been thinking in 21 years that I've immersed myself in the world of quality and safety in healthcare. What is quality and how can I simplify it to be very pragmatic about it? Basically it's this. You know where you're going. In your case, the deliverance of good care. Plan way ahead. Prepare all things you need to reach this goal. You've heard it all the previous speakers. See things coming and act. And here is the crux. When you didn't see things coming, you react. Learn from the things, we heard Olga speaking about that. Learn from the things you have not seen coming and act. And it's in the yellow marked line, there is where you waste your time. There is where you waste your time. You have not seen things coming and you react. And this is the ladder of culture safety. I was not surprised to see in Marianne her questions at how would you grade the quality system in Aruba? Was one of your questions. And I took a picture and I'm very sorry to say, but you think you're better than you are. I think that's my job to tell that when I started, you're all satisfied. I don't want to be your patient when you're satisfied like that. And it's very important to realize, where do you react? And I'm saying this as a good news, but sometimes to kick you in the butt and be inspired, no, you ain't there yet. You have to get up and start moving because you ain't there yet. So basically you have this ladder that takes you from, we don't care as long as we don't get caught. As inspection, we meet up with those kind of healthcare providers. The reactive ones, I know safety is important and they do the best, their best to analyze after an accident. But the baka hoga kaban to raban cheki konosas kepos. Sorry, Caroline, it was in English. You have the calculative system. So even if you have the best quality system in the world in place, or not, you will not always have what the question was for Dasha. How do you get people moving? Because it's a system. And sometimes you say, oh, we have a new digital system. And I'm always, oh yeah, what is it we're going to do with that? That's a tool. That's not a mean to a goal. It is a mean to a goal. It's not the goal. So what is quality? You heard Dasha telling you about quality. We all spoke this morning to quality. Actually, you want to have a smooth sailing, but actually there is no smooth sailing, like there's always something happening. So actually in rough seas, because a smooth sea never made a skilled sailor. So we're talking about the shift. We're talking about the mind shift. You heard this morning, about going from reactive to proactive, seeing the bigger picture. Firstly, you're just really maybe focusing on the leg or the ear from the elephant. And then you start anticipating. Remember the bit that I said, when you react, you lose time. You didn't see things coming. And from there on, you are more in control. Oh, I'm missing a slide. So actually, summing up, I think this is a feeling we all sometimes have. The whole day you're spending running behind fires and just, going on and putting out fires every day. Then you can implement a quality system so you have a continuous improvement. But not be fooled. The quality system is not your goal. It's your toolbox. It's the quality improvement culture you need. Just what Dasha told. They were every day in meetings, they were talking, they were inspiring each other. That is what you need, that's your horsepower actually. Because you have a beautiful cart, but that's your horsepower that will drive you to in your system. If you talk about, oh, thank you very much. Thank you. I love my team. This is the definition that we adopted from the inspection of the Netherlands. What is the definition for quality system? A coherent set of structures, activities, procedures, instructions, and records aimed at systematically assuring and improving the quality and safety of care delivery. These are the key components, and you will see you already had presented by Jabert the INK model, the Instituut Nederlandse Kwaliteit model. It's actually a little brother of the EFQM model. That's the European Foundation of Quality Management. It all stems from the end of the 80s, the beginning of the 90s. And these are the key components. So it doesn't matter which kind of, which type of, which quality system you want to adapt. These are the key components that you will find in any one of them. Vision and policy, the organization, processes, the people, resources, measurements, and the improvement. So the INK model, 21 years ago I started my specialization with this INK model, and I really like it because it simplifies it. You have more modules and you can have all these methodologies, systems, but I really like this one. It has 3 parts, just like Jabert already mentioned, the organizational bit, and what you can see that all the key components that I just mentioned, you can find them back in here. And it just gives you in your brain that you say, oh, if my keywords was only about staff management or maybe about processes, what about leadership? Where was the direction? Then you have the results part, that is the measurements, and of course then you have the improvement. This is also what Dash already told you, the plan, do, check, act. Here you can see how the dots are connected by using a tool. Don't be fooled, you still need your goal and your direction. It will help you get there. It's your vehicle. And in the beginning, it's just like when you start learning to ride a bike. Then you fall down multiple times and the only aim you have in your brain is that bike, and stay on that bike. You don't even know if you came to the end of the street or where you went. You're just focusing on the bike. So it's normal that if you start, and that's what Dasha says too, in their journey, in the beginning they were only focused on the bike, how to get to drive that bike so good as possible. And in time, then you see that it's a bike that will transfer you from A to Z. And then you start playing with it and getting comfortable with it. So, take home message. I think that it's very important, and you all already, you do have a lot of quality. I spoke almost 2 hours with the general physician telling me that I do not have time for the quality system, help me fill in my report. And I just asked, on all these 10 components of the INK model, what did you have there and how did you do that? And she could answer me questions, and I said, do you know, you already have a quality system in place, but it's not conscious. It's not, you were not even aware that you were already handling with quality. So it's implement an improvement culture. I will keep on emphasizing, it's not only about the tool. You need a tool to get to your goal, but it's the whole culture. Using a quality system. There are certain studies, I think Danielle Consalves, I met you in 2012 in the Netherlands, and we went to the same conference there in the Netherlands, and it was about the importance, the Duke study, and it was about the importance of the directors of the facilities, that they direct their people. Because one thing is to, for instance, if Jaco says it's very important for quality, and in nothing else what he does, you can see the reflection of how important he finds that, nothing will happen. Because when somebody comes knocking van Jacob, but we need this, and he goes like, nah, just mention it in every report, the quality. And that is what they already, in all the with the JCI and even in some, you already have seen that, the importance of the directors or from the top down. But without bottom up, you don't have wheels on your bike. Talk about quality improvement within your professional association. In Inspectorate, we have found out that the professional groups that exist on the island, they originate, the main reason that they came into existence was actually to negotiate with AZV, which is very logical. But they never have really in-depth discussions about quality. Here and there you see now within the professional groups they have quality commissions. I think HAVA has a quality commission within the HAVA group. They have the complaint commission. So you see that more and more happening, and you will have to talk more about quality improvement within your professional association, because what Jabet mentioned as well, it's still your own responsibility. And the more you come and you do from yourself, the less that, we have to choke you to do something. And this was mentioned too. Start. Dream big, start small, but most of all start. Even the ones that already have a certified, the laboratories, they have like eight times going already, round and round their certification, accreditation, but they still have to start over again. They still have to have that improvement cycle again. And of course, you see that they shift into it's more in their DNA, but still you would have to start. Quality is never an accident. It is always a result of intelligent effort, and we've got brilliant minds here today. Thank you very much.